And now I'd like to welcome Dr. Roger Cornwall. He's the Director of Hand and Upper Extremity Center at Cincinnati Children's Hospital Medical Center. Please give a warm welcome to Dr. Cornwall. Can I help you with this?
Yeah, sure. So I have no disclosures to make other than I too have 5 kids, although they're a lot younger and not nearly as mature and well-behaved as the military family you just saw multiple pictures of, including one 6-month-old who kept me up just about all night last night, so if I'm speaking in tongues, it's his fault. I just texted my wife, though, and said, make sure you give him some Gaia drops. We have those. We call them the happy drops. They work so well for babies. And I know nothing about oral care for patients with EB, so I'm going to get a different doc up. That was the And I also, as the hand guy, I'm going to take a sort of hand surgeon prerogative here, and I've been told in no uncertain terms that questions are supposed to be written down so they can be sent to me later, not spoken to me, but as the hand guy, the people who have probably the most burning questions for me are the people with the least ability to hold the pen to write it down, and so I will happily welcome questions from the floor at the end of my talk. Lest I be contacted by one of the very effective federal prosecutors for discrimination based on disability. So, and I also must disclose that Jerry informed me that I have the most boring title of any talk at this conference: Measuring and Improving Patient-Reported Function and Quality. You know, Jason Fisher has butts and guts, right? Loves using word butt. I don't do anything with butts, so I can't use that word. So instead, I turned to inspiration from a doctor whose work I have followed very closely for inspiration for a title of my talk. And so I've instead entitled it 2 Hands, 4 Hands. And that's not just because it has cool-looking hands on there, but the meaning of it will be very obvious in just a couple of minutes. So we all know a lot about epidermolysis bullosa in this room, so I don't need to go over all of these different subtypes, but other than to say that we're focusing on the recessive dystrophic, which, as you know, leads to nail loss, loss of the web spaces, digit contractures, and ultimately dermal cocooning. And you can perhaps slow the progression of this with wrapping in between the web spaces, but ultimately the digits contract and fuse into a cocooned hand. And this can happen as early as the first couple of years of life. It's not something that happens at a set rate over time. So in a past life, when I finished my hand fellowship and pediatric orthopedic fellowships, I started working doing nothing but pediatric hand surgery at the Children's Hospital of Philadelphia. Pretty high volume area, doing nothing but children's hand surgery, and I didn't see a single patient in 5 years with EB. I had heard about it, it had frightened me, but I didn't see any patients with it, and I thought, you know what, it's probably that rare. But then I moved to Cincinnati Children's Hospital to get closer to my wife's family, and lo and behold, Rich Aziz Khan and Ann Lucky called me up and said, hey, you're a new hand surgeon here, why don't you come to this clinic that we have? And so I encountered patients with recessive dystrophic EB who would ask me what I wanted to do with that. And so the hand surgery at that time was being done by Peter Stern, who is the former chair of orthopedics at University of Cincinnati and my boss. And I was the new guy, and so I would go to the clinic, because I was working at the Children's Hospital, and I would see these patients, but it was my job to decide who needed surgery and then send them to Peter Stern to do the surgery. And so for the first literally couple of years, I didn't want to step on his toes by doing any surgery, so I just started learning how to indicate the surgery. Now, the first thing you do when you're confronted with something you don't know is go to the textbooks, right? And so you go to the textbook, The Growing Hand, which is sort of the Bible of pediatric hand surgery, or was at the time, and there's a chapter on it that says you should do this, right? Take all the skin off the hand, open it all up, put skin graft on the entire thing, put these fancy bandages on it, stick a whole bunch of pins and a big apparatus around the hand, and then a big splint worn from now until the end of time, which gives you a hand that looks like this, which is a really good hand in a textbook, but the fingers don't move. It's essentially a ping pong paddle at the end of the arm. But that's not what's discussed in the chapter, they just show these pictures. And I thought, well, that doesn't sound like a great idea. And then you have patients who have had such surgeries who come in and say, this is what my hand looks like, and what they say is things like, it took forever for the hand to heal, the donor site never healed for the skin graft, the contractures came back in a few months and it really didn't help me at all, and I'm never having hand surgery again. So again and again I went into patients' rooms and said, hi, I'm the hand surgeon, how can I help you? And they said, you can't, go away. We're not having hand surgery. I'm like, okay, well, that's easy, now why don't you tell me why not? But then every now and then you'd run into a patient like this who would say something like, I was doing fine until I lost my thumb. I remember the day I lost my thumb. I want my life back. Is there anything you can do for me? And that brings us to the topic of 2 hands, 4 hands, or better yet, 2 hands, 4 hands. Which brings up what I attribute to Pete Carter, the 2-4 rule, where you can do things 2 hands, and by and large I'm paid by insurance companies to do things 2 hands, but really I'm in the practice of doing things for children. And you can perhaps do things for children without doing anything to the hands, but often that's not enough, especially in recessive dystrophic EB. But after a certain point, you keep doing things, you're really not doing anything for the children, you're just doing more and more to them. And so we want to find the sweet spot, really, what is just right, where you're doing just enough to them to get the maximum amount of benefit for them. And so really without good textbook or even literature support, good dozen series or so out there of surgeons doing various things to the hands of kids with EB that are all very, very different and all have the surgeon saying, I liked it, right? But they're all very different. So without good guidance there, I went to the patients and asked 2 questions to every patient I met. What can I do for you, and what do you not want me to do to you? And pretty routinely, what people wanted done for them is to get their thumbs back. And maybe this is because of texting, right? There's nothing useful for opposable thumbs before text messaging was invented. But it was a recurring theme. And also, there were several recurring themes on what people didn't want done to them. First, they didn't want a non-healing donor site for a skin graft. Second, they didn't want their dressing changed. The first dressing post-operatively changed while they were awake. It was the pain of that dressing change that ruled out hand surgery for many of these children who had had hand surgery before. And they didn't want to wear a splint that they had to wear the whole time they were recovering because that stopped their hand from being used. And so from that guidance, I developed a surgical strategy, which involves focusing on improving the distance between the thumb and the rest of the hand, something I've sort of called the first web space inlet width. And the first child I did wanted to eat a McDonald's cheeseburger without having to take the patty out of the bun, eat it separately, and then smash down each half of the bun until it was thin enough to squeeze in that space. He wanted to get the whole thing, bun, meat, pickles, bun, in his hand at the whole time and take a bite. And so this became affectionately known as the cheeseburger procedure. And I like using graft, and there's a lot of debate as to whether or not you should cover them with graft. And I know Amy Ladd quite well, who's at Stanford, and she doesn't use graft at all. She says, oh, these people have no trouble making skin. Okay, but it takes a long time, and during that time, the contracture could be recurring, and they don't get to benefit from the use of the hand, so I like to use skin graft. But rather than taking a big piece of skin graft from the abdomen, which as soon as you stand up gets stretched and opens up, I like to use skin graft from the medial and anterior elbow, which is immobilized in flexion in the postoperative dressing that you see here, so it actually has a chance to heal in that first 3 weeks and have many fewer problems with wound healing from that donor site. And then the first dressing change done at 3 weeks is done in the operating room under general anesthesia, which gives an opportunity for oral care if it's necessary or another esophageal dilatation so as not to waste the anesthetic experience. And then any pins that are used during the time where the skin graft is healing are pulled out at that time, and so they don't have to experience the pin pulling as well. And then back to wrapping the hands, primarily wrapping in the first web space to pull it down, just to increase web space depth, but no splints. The question, though, is this a good strategy, right? So I mentioned a dozen or so series, and all of those series where surgeons did certain things, they then asked themselves, did I do a good enough job? And they used various objective measures to determine if they did a good enough job. And so as a surgeon and as a dad, I can say, yes, it is a good strategy because I said so, right? But it doesn't work on my kids, so why should it work on my patients? And so, rather than asking the surgeons to assess whether or not it was a good job, since I asked the patients what to do surgically in the first place, why not ask the patients whether or not it did anything for them. And so to do that, you need validated patient-reported outcome measures. And at that point, there was nothing reported in the literature. The use of a validated patient-reported outcome measure of hand function or even quality of life used to assess the impact of hand surgery. And so that brought about some research. First, to see if we could measure patient and parent-reported hand function and quality of life in children with all different subtypes of EB. But then second, to use those validated measures to determine if the effect of first web space contracture release really improved patient-reported hand function and quality of life. And so we looked at a number of different hand function assessment tools, and there are a number that are used specifically for children, and settled on the Able Hand Kids, which is a tool that was initially designed for children with cerebral palsy who have a roughly similar amount of hand impairment, and is specifically for children with CP who have normal cognitive function, roughly the similar amount of hand impairment as those children who are needing surgery in EB. And it assesses how easy or difficult it is to perform 21 different activities of daily living with a score that ranges from 0 to 42, where higher scores indicate better hand function. And then we also use the quality of life in the epidermolysis bullosa questionnaire, which, as you probably are all familiar with, uses 17 items assessing the impact of EB on the quality of life, where the greater the score, the greater the impact, so the worse the function is. And so here, lower scores indicate less impact and thus a better quality of life. And so we took these two surveys and mailed them out to 102 patients that we have in our clinic with a whole variety of different subtypes of EB. And through a relentless phone follow-up on the behalf of our study coordinator, Emily Eisman, we got 71 patients returning questionnaires from 20 different states that had come to our clinic. Mostly, these were all children, average age of 9, half girls, half boys. The largest group was the recessive dystrophic, and that's not because of the relative prevalence of the disease, but that's the relative prevalence of kids traveling to our center. And what we found, not surprisingly, is that the summary score, the total score for hand function, was worse for recessive dystrophic than it was for any of the other subtypes. But not all types of hand functions are the same, so you can't just look at the overall score. And so this hand function test has a variety of categories of hand function, unimanual hand function and bimanual, and various subcategories of that. And what we found is that if you rank the difficulty of all of these functions for the recessive dystrophics, the majority of them are ones that require grasp in both hands. So bimanual activities that require finger or hand grasp in both hands. And that was true across all of the different groups. So 2B and 2C are the lowest in all of them, all of the different subtypes of EB. Now, quality of life, as you know, is severely impacted by EB, and that was certainly reflected in this quality of life survey, where almost everything was affected either a little to a lot, which is in yellow, or a lot to severely, which is in red. And again, not surprisingly, the worst quality of life, or the highest impact on quality of life, was in recessive dystrophic, and there was a significant, strong correlation between quality of life and hand function. So the quality of life score on the y-axis and the Able Hand Kids score on the x-axis. So, and that correlation existed for all subtypes of EB, and overall hand function correlated with almost every item on the quality of life survey. So while hand function may just be a marker of disease severity and its other disease components that are affecting the quality of life, every aspect of quality of life seemed to be affected by hand function. And so we put this together in a paper with the conclusion that hand function and quality of life can be measured from the patient perspective, which set the stage for our second aim, which is to determine the effects of hand surgery, specifically this opening of the thumb, the cheeseburger procedure, on patient-reported hand function and quality of life. And so while we've done many more surgeries than this, we studied prospectively the first 5 after that first paper was done with recessive dystrophic EB, who all had their thumb web spaces opened with the skin graft, and 2 of them had concomitant middle and ring finger contracture releases. And I should be clear, by first web space release, I mean opening the thumb away from the hand in this direction, also if it's contracted across the palm, but in many cases, opening the index finger as well, purely to increase the width between the thumb and the next nearest digit, to increase the size of the cheeseburger that you can fit in your hand. And we administered the able hands and the quality of life surveys preoperatively, and then 3, 6, and 12 months postoperatively to see what changed. And here's an example of one of those thumb releases in a very mild case of thumb contracture. Here's a more moderate case of thumb contracture, and then a more severe case where the thumb had been gone for years. And what you see is, if you look at each individual patient, is that as a whole, the group improved over 3, 6, and 12 months postoperatively, but there were some kids who improved a lot and some kids who didn't really improve much at all. But if you average them all together and look at the different groups of hand function, the types 1, the unimanual, and 2, the bimanual tasks, they all improved gradually by 12 months. Similarly, if you look at the percentage of the questions, or the percentage of the items on the Able Hands questionnaire that were listed as impossible, that decreased, with even one patient saying nothing was impossible. I like that attitude. But again, it's highly variable between patients. We also learned, just by looking at this very small group of patients, that the early worsening of function, there were some kids who got worse after the surgery and then ultimately got better. Those were kids whose graft didn't take initially completely and had a partial wound that still had to heal, which argues for using a graft, right? Because if you have the whole hand not healing, or not grafted, and so you have a wound there, that could actually take away this early functional gain. And that the late loss of improvement, so at the 12-month mark, was due to recurrence of the finger contractures, and that's consistent with the literature, that the thumb can stay open much, much better than the fingers can stay open postoperatively. The really troubling part is that this did not seem to drive, in large part, an improvement in quality of life. Overall, there was some improvement in quality of life, and again, down is good because that measures the impact on quality of life, but it wasn't a significant driver of improvement in quality of life. So we haven't quite nailed it in terms of getting just that sweet spot. In some kids, we probably did a little bit too much, and in some kids, we probably didn't do enough. And so, first and foremost, I will be the first to say that EB is not a surgically curable disease. I will not solve this problem. I'm only trying to do as much as I can to try to help people cope with the disease until much smarter people at Stanford can cure this. It's also a very small sample. Again, we've done many more than these, but we've only looked at these 5 to prove the utility of using these patient-reported outcome measures. And we're only looking at thumb releases, and I'm not saying I never release fingers, but I have to be talked into it, and so we'll have to see in a larger group how those work. And indeed, it is short-term follow-up. 1 year might sound like a long time, but it is relatively short-term follow-up because these can recur. But the real thing is, are we measuring the right things, right? We've got all kinds of questionnaires that take years to develop, and in the years they take to develop, people stop doing things as archaic as writing, right? And they start texting. And so here's a girl who couldn't text, and at age 13, that is socially crippling. And so she couldn't get her phone into there. She could get a pencil in there. She could write just fine. She didn't want to write. She wanted to text. And so we opened her up just enough to get a phone in there, and here she is texting. And hopefully you'll be able to see that. It's just sort of blinding speed. She was actually texting me something. So even from this information, we can make a few conclusions. First of all, that patient-reported hand function can be measured in EB, and I would submit that it should be measured in EB in lieu of, if not in addition to, the provider or physician or therapist's report of hand function, because really what matters is the patient's report of hand function. We know that hand function correlates with quality of life. We haven't quite figured out how that correlation is, but we know that it correlates. And we also know that low impact, sort of a la carte, what can I do for you hand surgery without filleting the entire hand open can improve patient-reported function. But we need to continue to evolve our techniques of measuring this hand function. So to go back to this kiddo, I think after all of this, after a few years of doing this, I have at least a suggestion of what to do. So we gave her a thumb, which she hasn't had for many years, and I'm eager to see how she does. She was just done about 2 weeks ago, so she's still in her dressing. So thank you very much, and again, I would be happy to take questions. And I am the last speaker, so talk all you want. Yes? So that's a really important question, the timing of it. So if you didn't hear the question, is how do you time the releases? Do you wait until it's really bad, or do you try to proactively prevent contractures from getting worse? So in the fingers, it's a little bit of a trickier subject because the really mild ones are the ones that you can get out straight. The ones that are all the way down take way too much work to get open to make it worthwhile, because by the time those have all healed, the fingers tend to have come down, or they get stuck in a straight position, which is not helpful for grasp or pinch. But at the thumb, I think there really is a sweet spot. So often, and I'm sure most folks here will know, the thumb stays in a certain position for years, and then over 6 months it really starts to come in. And that, I think, is the right time to act, because if you wait too long, as you open it up, just geometrically, you end up with a much wider area that you need to cover. And I, again, do like skin grafts, and I do like skin grafts from the elbow, but there's a limit to how much skin you can get from the elbow without causing a non-healing wound. There is no limit to what you can get from the abdomen, but that means there's no limit to the size of the non-healing wound you'll end up with later on. And so I don't want a thumb that's all the way in, because that just means there's less I can do, because with the available skin graft, I can only get it open so much. But as far as being proactive, I'm not sure that doing it early and often is the best thing to do, because again, we're trying to improve the patient and parents' report of their child's function. And so if they don't have what they perceive as any functional deficits, all I'm doing is something to them. I'm not going to be able to convince them that I've done something for them. And yeah, it hurts. There are complications. Every trip to the operating room is an opportunity to be injured. And it's, no matter how careful we are, and we do a lot of EB surgery in Cincinnati, and it's still very challenging. So I don't want to try to talk people into surgery. I would rather have people talk me into surgery. And just at lunch, I had a patient that I've been seeing here for a while, or in Cincinnati for a while, come up to me and say, you know what, I think I'm ready. That's the patient who needs an operation, in my opinion. Yes?
Yeah, do you think if maybe you were to use the sheets that they're developing that has the collagen 7 protein after you do the hand surgery, you think maybe there'll be a less involvement with re-webbing after that's done?
So I can't answer your question specifically about the re-webbing, because I don't know that we have, or I don't know that the folks at Stanford have a long enough follow-up to know what happens to those wounds over time. And I think 25 weeks was the longest follow-up that they showed, and that was in that one patient, and that's still pretty early in the process as far as hand surgery goes. So I don't know specifically, but I can tell you I'm pretty excited about that stuff. I don't want to take skin grafts if I don't have to. I think the results justify doing it right now, but in the future, I don't want to keep doing that. All the currently existing commercially available skin graft substitutes don't tend to do much, and a lot of people have had experience with that and have not been thrilled with it. And so I think it's still better to have your own skin there, even if it is EB skin. But if you could put your own skin there that's not EB skin, oh, that's fantastic. In the front and then back. Mm-hmm. I have not personally used Apligraf or BioBrain or any of the various skin graft substitutes, other than spending time talking to colleagues who have used them and have moved away from them. And I don't know if there's enough long-term information on enough folks to know, but certainly there can be results that are very idiosyncratic. So one person, the contracture can come back faster because they didn't have graft, or one person, the contracture got worse faster because they didn't have a graft. So And in the adult patients that we do see at Cincinnati Children's, I will let them tell me what works best for them. And so I have a brother and sister who have had hand surgeries without grafts, and as they said, as long as you do that first dressing change under anesthesia, I'm fine with doing the dressing changes thereafter. Don't do skin grafts on me. I'm totally fine without them. And I'll let them tell me that too. Mm-hmm. Right, absolutely. Without a good solution to the problem at hand, which is, so to speak, which is the skin tightness, I don't know that the skeletal structure or the muscle tightness will ever become a limiting factor. But once the skin problem is solved, that is a very, very important point. Because if you immobilize developing body parts that are supposed to move and they don't move normally, they won't develop normally. So not just muscles being tight, but bones not being shaped properly, joints becoming dislocated and not being able to be realigned. And so there are, and even blood vessels. So I've done finger releases, yes, I'll admit it, where I'm limited not by the skin, but by the blood vessels and the nerves on the palm side of the finger. I can't straighten the finger out because I'm going to stretch the nerves too far, or I stretch the finger so far it turns white. So a lot of other structures are sort of collaterally involved, but not to the point of becoming a limiting factor when the skin is still such a limiting factor. So I'm absolutely looking forward to the day that the skin problem is solved, and then at that point, I think once we have a good answer for that, then we need to keep the fingers supple. Now, there are many, many patients who don't have bad enough hands to need hand surgery. And in those kids, it is absolutely critical to keep the hands moving. And our occupational therapist would certainly agree with that. And I have this love-hate relationship with the iPad. I love it in the third row of the minivan on a trip to Michigan for the kids, right? Amen. I love that it can allow kids with really severe hand impairment to communicate and get things done. But it also doesn't inspire hand movement. And so there are lots of kids who are on the border of losing hand function, who will lose hand function faster because they don't do things that require hand function. And you can use the iPad with your nose. I've tried it, it works, right? And so keeping the hands moving when they can move, I think is absolutely critical. Mm-hmm. I don't know. I like hands like moving, right? Hands are like racehorses. You wouldn't tell a racehorse to just lie down and get better, right? It won't do well. So hands need to be moving to really have optimal function. And a stylus is kind of like using the knuckle and your pinky. I don't know that that's enough movement. Yes. That's a very good question, and I don't think there is a good answer to it. If you look at most folks early on in the stages of the syndactyly, or the loss of the web spaces, you'll see little tiny fissures in the skin on the back side of the hand, which causes a little bit of scarring on the back. And if everyone looks at their hands, you'll see that the web spaces are slanted, right? They're further out on the palm side than they are on the back side of the hand. And the earliest sign of the loss of that web space is that obliquity is lost, because it starts to pull together on the back of the hand, right? And then that just gradually progresses. there are certainly kids who have a blister and a wound that then heals tighter and then it recurs over and over and you can clearly see it. But there are kids as well who don't have problems with blisters or wounds or infections in the hands and they end up with the cocoon deformity. Teleologically speaking, meaning if EB had a brain and a mind and it wanted to do things, or if your skin had a mind and it wanted to do things, you would say if you have a problem making skin, you would want to cover the lowest surface area possible, and the surface area of your hand in a fist is much, much lower than the surface area of your hand with all your fingers opened up. So to some degree, it's conservation of skin to bring the fingers in. That's the best answer I can make up for you today, sorry. Any other questions? No? Okay, well thank you. I'm here to learn as much as I am to teach, so thank you for all of your input over the years.